Good afternoon, everyone, and thank you for joining us for our single topic webinar on brief interventions and that build resilience. We thought this was a really appropriate topic to bring to you guys, especially in light of COVID and where we're at right now. So I'm going to go ahead and turn it over to Wendy Bradley. Most of you know her from our previous work, as she's one of our experts that come in as one of the consultants. But I'll let you, Wendy, introduce yourself. I'm going to give a little bit background for those who have not met you yet.
Sure. Thanks, Wendy. We share the same name. I appreciate that. So my name's Wendy Bradley, and I'm actually here in Nashville, Tennessee. Though I have worked all over the country, my current role is I support practices that are part of CPC Plus and also Primary Care First, and several other CMMI models that promote value-based reimbursement. And I particularly work around behavioral health integration. I think as many of you know, I started at South Central Foundation in Alaska, and I was there almost 9 years and led their behavioral health integration. So this is near and dear to my heart. I spent a lot of time in clinic seeing patients myself. So what I'm planning on us kind of spending some time around is just how to provide a brief intervention. I've gotten a lot of questions lately from different practices and even behavioral health clinicians about, I'm seeing a lot of people that are in distress, they're subacute, I'm in primary care, I'm still having a hard time getting out of the room in less than 45 minutes. They start crying. I'm not sure what to do. And so we're going to just spend some time around some brief interventions that are evidence-based that I found pretty helpful. And as you guys hear me as we go through some of this, please jump in the chat with any questions. If you want to jump in with some of your own ideas, I'm sure you have some great brief interventions that you use as well. Please feel free to, jump in, raise your hand, come off mute. Hopefully this is a good discussion. I always learn a lot in doing these myself. So, all right. So we're going to talk just briefly around anticipated patient risk, needs, and stress-related conditions. Look at the contextual features of a brief intervention, and then I'm really going to focus a little more on acceptance commitment, therapy approaches, and motivational interviewing based assessments and interventions for different populations in healthcare settings. So one of the things I will say is these interventions really can be done by anyone. You don't have to be a licensed behavioral health clinician to do them. And they really have a big impact in a couple of sessions. So this does not have to be ongoing, 50-minute hours over 10 visits. They actually really have a pretty good efficacy for just 1 to 2 shorter sessions. So just sharing some recent data that was released and just looking at the prevalence of mental health. And so this was done by Mental Health America. You can see kind of around the country, the prevalence with red being the highest and yellow being the lowest for prevalence of mental health. This was a spot check that they did from January to June versus January 2021. And you can see the prevalence for anxiety and depressive disorder was about 11% in 2019 and then about 41% in 2021. So you can see we've got a pretty steep rise in anxiety and depressive disorders. I doubt this is a surprise to anybody, but seeing it on a slide, I think kind of was a little jarring for me. And then even more, concerning in some ways when you really look when you break it down by age, you can see that the young adults 18 to 24 have the highest, with the adults over 65 being the lowest. And you can see it kind of goes down by age. And I've actually seen some other data from 12 to 18, and theirs is substantially higher as well. I don't know if this matches kind of what you're seeing in your clinics. Yeah, Ton says this data is staggering to see a graph like this. Yes, it probably in some ways is validating for you in clinic, because you're probably feeling this, and now you can see data supporting it. This is adults with serious thoughts of suicide, again, with yellow being on the lower end and red being on the higher end. You can kind of get a sense of what that looks like. Like I said, worked in Alaska for a long, long time. And, you know, it used to be when I was in the lower 48 that your highest time for suicide was around the holidays. But in Alaska, and I don't know if this is true for Washington, but people used to think that if they could just get through the winter, and to break up in April, they could just make it to April, things would be better. But when things didn't get better, that's when we actually saw a rise in serious suicide thoughts. I have kind of wondered, you know, with COVID, if people are thinking, you know, if I can just get through to the vaccine, if I can just get through this, then things will get better. When there still is kind of that stress, you know, is that even a risk factor? Thanks, Wendy. I noticed that you put a report there in the chat that you guys can take another look at. So prevalence of youth substance abuse is also on the rise. Interestingly, I saw another report that showed that opiate use has gone down, but we're seeing a rise in marijuana, especially among that 12 to 18, and I think methamphetamines. So we're seeing, I think we've seen this I think we have a substance use group here on the phone, and I think we have seen this over time as we have a big push to bring one thing down, and as we're bringing down one substance or the use is less, another one starts rising. A lot of times I think because we're not really looking at some of the core issues that push that. So we're seeing a rise in youth substance abuse, and I think vaping is also on the rise. I don't think it was included in that report, but I've heard that it is. I don't know if that's what y'all are seeing, but I've heard that or seen that in some reports. Anyway, I'll pause really quick. Any thoughts on that data? Does that seem consistent with what you're seeing? You can chat in or come off mute, whatever you guys feel like.
Wendy, I'm curious on that increase in youth substance use, which includes marijuana. Is there any correlation to those states who've legalized marijuana and which is now becoming more normalized in homes?
Yeah, actually, I think I'm not sure if it's the same report you put in here, but they actually looked at Colorado in particular because they have the most data in Colorado, and there has been a steep increase. And it is corresponding with higher increases in depression as well. So I don't know if it's a chicken or an egg, or if there's higher increases in depression, anxiety, which leads to more marijuana use, or vice versa. But there does seem to be a correlation there. And I think I can probably put the link on the entire youth report or send that out so you guys can kind of skim through that data. They really go state by state too.
Wendy, I saw a meme this morning that said, Now's the time that if you find out whether it's seasonal depression or regular depression. And I was like, can it be both? But I just thought that was kind of funny, but also like sobering.
Yes, I think that goes right along with what we're talking about. Yeah, part of me feels bad for chuckling about that, but I guess there's some truth in that. I guess if we don't chuckle a little bit, we might cry. I don't know. And then Ton says the Freakonomics podcast just had an episode going over some of the research on marijuana use, looking at Colorado and Washington as early adopters of legalized marijuana. So I'm curious as to what that's also bringing up. So interesting. All right. So yeah, please continue to share. If you have any other ideas, jump in. So let's look a little bit, let's take a deeper dive into some of the brief interventions. Again, I think all of us are pretty busy right now, not just with patients, right? We're also doing this with family members in some ways. I think everybody's experiencing a lot of change. So one thing I do think about is change also breaks sort of that hypnotic rhythm that we get into in our lives. And I'm also finding a lot of people over the last year kind of reevaluating things. When we take a step back from our life, it allows us to kind of change and look at things differently. And I really like this quote about people change for two reasons. Their minds have been open or their hearts have been broken. And I think we've seen just a lot of that. And in some ways, as much of the heartache that we've experienced over the last year, it also provides an opportunity for change. And sometimes just kind of getting out of that everyday grind and taking a step back allows us to kind of decide, which direction are we going to go and what really matters to us, for ourselves and for our patients. So when I say a brief intervention, generally it's a brief conversation. And this says 3 to 5 minutes. And I know Expert kind of sets these guidelines initially, but I probably think about them a little bit more broadly. They might be anywhere from 3 to 15 minutes. But it's really about the goal around a brief intervention. And it's really feedback. It might be some advice, highlighting ambivalence, an emphasis on what can the patient do in the situation, what are their options, and then providing a variety of ways to affect change. And, we use motivational interviewing quite often with brief interventions because we're really looking at a patient's own motivation for change, helping build confidence, taking small steps. And some of the techniques include obviously an empathetic style, support for the patient's perception, and also just assuming they're the expert on their life, which they are. A lot of times we may try, get stuck in giving ideas or too much advice, as opposed to really kind of pulling out what works and what doesn't work in their life. And then reinforcing optimism that they can make a change, that they do have choices, they're not stuck. And then the context of the population for any brief intervention, it can be done in multiple settings. It could be done in a behavioral health setting. It could be done in primary care, got people in the ER, working on something right now for EMS, emergency medicine, so first responders, to learn how to do a brief intervention. They can also be preventative because certainly in primary care and behavioral health, we're doing preventative screenings. So it allows us to have conversations earlier in the process versus talking to us when they can't stand it anymore. So we're able to screen for depression and substance use and start to look at behaviors when they're at risk or when people are stressed to get coping skills in place early so that when that big stressor does happen, they're better prepared to manage it. It's really a whole person approach. We're looking at someone's emotional health, their spiritual health, their relational health, their basic needs, social needs, of course, which is getting a lot of emphasis right now. But those of us in behavior health, and if y'all can remember the DSM-4, this was part of our 5-axis diagnosis, right? We always have looked at basic needs. And I'm thrilled that it's becoming just part of routine care in primary care, because someone can't pay their electricity, they're not going to be able to keep their insulin cold, you know, or those basic needs aren't met, they're not going to be able to get to their appointments, transportation, you know, or just pay their bills, housing, all of those things. So physical health, obviously, sometimes physical health, if someone's in a lot of chronic pain, it's going to impact their mental health, emotional health, spiritual health, relational health, and their basic needs if they can't get a job. So all of these things work together. So we're always looking at all of those and looking at kind of what's doing a sort of a root cause analysis, since you guys have been learning about improvement science. I think our behavior health approach very much aligns with improvement science, just on a more one-to-one personal level. And then the level of care to match the level of need or capacity. So what that essentially means is not everybody needs to go to long-term therapy. Sometimes someone needs to learn a skill to get through this situation. And it can take just 5 to 10 minutes. Sometimes someone just needs to talk and talk something through and, you know, bat around some ideas to figure out what their next steps are. So kind of looking at a different level of care, and that in primary care, certainly it's more longitudinal. As the BHC working in primary care, I have the same type of relationship that my primary care provider does. So as long as that patient is impaneled in the clinic, I'm part of that team, and that patient has same-day access to me as well. So a different type of relationship. And just to give you kind of an idea of where brief interventions sit in a stepped care approach, when I say brief interventions, this is something everyone can do, like I mentioned. And it encompasses a number of things, you know, basic problem solving, basic listening, basic advice giving, basic care planning, and also a culture of humility. Again, assuming that that patient's the expert on their life and they're going to teach me about what works and what doesn't work. And I'm going to ask questions so that I understand the context, that whatever struggle they have, I understand the context that it's occurring in. So I'm asking a lot of open-ended questions. Brief therapy, sort of that next level up, it's a little more structured.
Can you guys hear me now?
Yep.
Okay.
Yeah.
I just got on my computer. It looks like my phone just, we've had a lot of thunderstorms today, so I think we're having some problems. So sorry about that. You can't do a presentation without having some sort of IT issue, I guess. So, so just kind of looking at the step care approach, again, brief therapy, a lot of what integrated behaviorists do, kind of a generalist primary care behavioral health approach. Then we have psychotherapy, medication, intensive outpatient, and inpatient. So we're kind of focused on the brief intervention piece here. So I'm going to jump into some acceptance commitment therapy. And just so I kind of have an idea, how many of you are aware or are familiar with acceptance commitment therapy? as a modality? If you want to just put in the chat yes or no, just give me an idea. This is completely new for you, or if you're familiar with this. No, okay. Nope. All right. I've got a few yeses and with exclamation, because Maxwell, if you have used this, you probably really like it. I really like it. Somewhat. Okay, Chris. All right. So this will be a kind of a short primer. I might give you a couple of interventions that I think, because this certainly can become more complex, but the idea around it's very applicable. But essentially, I'm going to start with this quote, but it's not hard to make decisions once you know what your values are. It's really at its core, helping people align their values with their behavior. And this is where I'm going to kind of splice in some motivational interviewing, because motivational interviewing is good for the basis of every visit and really is applicable in most modalities, but it's consistent and aligned with acceptance commitment therapy as well. These two start off the same way. So every brief intervention kind of walks the same pattern, is using basic reflective listening. So and that means you're basically saying, what I hear you saying is, and then you're repeating what they're saying because you want to make sure that you have it, and empathy. And reflective listening, I know it sounds like a very simple skill, but what that allows us to do from the very beginning is to connect and align with the patient. So that patient knows that we've got it, that we understand their pain and we understand what they're going through and we really get it. So if we have to sit here long enough to make sure that they know that, that we've got it. And so actually, I think I was telling our team a little bit ago that I was reading something. It was actually from a book called Never Split the Difference. It was on negotiating. I thought it was a very good point here, and it's very applicable to healthcare. But one of the things that when we're working with a patient, we never, ever want to hear from a patient, "You're right." If we hear "you're right," that means they just want us to shut up and move on. We've talked enough, right? What we want to hear is "that's right." It's a subtle difference, but that's right. When someone says to you, "that's right," that means there's a connection. You've got it. So reflective listening and empathy are key to building that alliance and moving forward. The next thing is open-ended questions. So we don't ever ask, "Are you taking your medication?" Because that's a yes or no question. What we want to ask is, "Tell me how you're taking those meds. What's your routine look like?" We want to hear from their perspective. Again, they're the expert on their life. Asking questions like, "When did this start? How did you get through this the last time you went through it? How long did it last?" Open-ended questions give us enough information to kind of know where to go in the intervention. And then prioritizing the work. Basically asking a question like, if we could take one thing off your plate today, what would it be? A lot of the patients that we see that are in distress don't sometimes know how to prioritize. They're taking in all of yesterday's issues and all of their fears about tomorrow, i.e. COVID and all of this, into today. They do not have the capacity, none of us do, to take care of everything today. We've got to move everything away and focus on what's right in front of us, especially when we're dealing with a lot. So one of the things that we can do is role model for patients how to prioritize the work and let's move everything else and what's the one thing that we're going to focus on. And that's also important, helping them build confidence to get through this. So asking that question, if one thing could change, what would it be? Or if we could take one thing off your plate today, what would it be? And then looking for strengths. Finding where the patient has been successful in the past. How did you deal with a stressor before? What gives you strength when you're going through a lot of hardship? Who do you reach out to? When do you feel most alive? Asking questions to really dig for those strengths, because a lot of times when people are in distress, they forget who they are. They forget what they've accomplished, and they forget that they have a lot of what's inside of them already to get through something. So it's our job to kind of ask those open-ended questions to help get to some of that. And then we're highlighting ambivalence. And what I mean by that is as we're listening to the patient, figuring out, we hear them saying they want this thing, then everything that they're doing is going in the opposite direction or is inconsistent with what they say they want. So let's say that they say they want to meet, pick up their child every day after school, but they start drinking at 2 o'clock. You're highlighting that ambivalence and what's going on and the discrepancy kind of between those two things. Or they're waffling between yes and no. Yes, I want to change. No, I don't want to change. I'm kind of stuck in the middle. One of the things, I know this is going to sound funny, I also talked to our team about this, but a lot of times when we're working with a patient, we want them to say yes. That makes us feel better. And we have to break the habit of trying to get someone to say yes, because a lot of times people say yes because they feel pressured to. Sometimes it's better to ask a no question, like, have you given up on making this change? Or trying to understand kind of where that line is instead of trying to get someone to agree with us. We want them to feel comfortable saying no to if they need to. That's kind of where the conversation really starts, when we kind of see where their lines are. Then exploring options and teach back, sort of the last part of how we sort of wrap that up, is looking at options, and asking for permission. Can I share some ideas with you? I've heard a couple of patients try this. Do you mind if I tell you what that is, whatever that is? So first, kind of asking for permission and sharing a couple of different options so people can choose. The more you get their voice into the conversation, the more likely they are to do it. And then teach back. You guys have probably had a lot of conversation about teach back, and teach back is simply ending the conversation with, what do you understand about what we talked about today, or what are our next steps? And more often than not, that patient got a lot of different things out of the conversation than you thought they did. And so this gives you a chance to align and get on the same page. So before, I wanted to kind of give you this foundation before we kind of walk through some of the other pieces of acceptance commitment, because these motivational interviewing basics really happen at every visit all the time, no matter what we're seeing a patient for. And I will say one other thing about this, it's kind of cool, is they've done some studies where they looked at how much time providers were spending with patients. And when providers used reflective listening and empathy, open-ended questions, they actually got out of the room a few minutes earlier. Their visits were more efficient and more productive than a provider that simply provided direction and some basic diagnose and treat, because when a patient doesn't feel heard, they continue to bring up other things. So when we use these, it actually creates for a much more productive, efficient visit with a patient, and also role models basic prioritization and problem solving, which when someone is in crisis, it's really hard to do sometimes. We feel overwhelmed. Any questions real quick before I move on? All right. All right. hearing a little background noise. So I'm either thinking someone's thinking about a question. I don't know. Feel free to jump in. All right. So one of the first this is a very basic intervention, and it kind of goes along with what we're talking about, but and you probably have heard it, it's called ask, tell, ask. And that means I'm eliciting permission, gathering information, or I'm asking permission, ask what they already know. I'm providing some information or options, then I'm asking what they think. And this is a super simple way to have a conversation with the patient. So ask, tell, ask, easy to remember too. All right, so that's a very basic brief intervention that you can use all the time. Now, when we get to focused acceptance and commitment, there's good empirical support for use with chronic pain, chronic conditions, behavior change, substance use, depression, anxiety, work dissatisfaction, and relational issues. So a lot of things that we see in both primary care and behavioral health. There's growing research for smoking, diabetes, weight loss, and so a number of different health-related concerns. And people can have radical change in 1 to 2 visits. I know radical is a strong word, and it makes you probably really curious about, like, what is this? But it really does have, I've used it over and over, and it has a profound impact, I feel like, when we can have these conversations. I'll jump into a little bit more about why. But we also set the expectation with patients at every visit that we're looking at, building confidence, and that we're really focused on having a change conversation. Most of the time when we're seeing patients, they're motivated to change just from the fact that they're with us, or they're in pain. And then this is core to focused acceptance and commitment approaches, is they believe that what prevents a vital life is our want to be symptom free. Now I'm going to let that sink in for a moment, because I think that we see so many patients that are coming to the doctors frequently, or to primary or to behavioral health, because they think that the goal is not to have any pain, to have any symptoms, and that they are putting their lives on hold until they feel happy. And so the goal of this is learn to live despite the pain, whether that's emotional or physical. And it's the acceptance. This is where that acceptance piece comes in, to engage in life while suffering. So again, live despite our pain, which is sometimes almost a radical concept for patients. And I think sometimes as healthcare providers and behavioral health clinicians, we feel this need to make someone or work with them until they're completely symptom free. And sometimes that is what happens, but sometimes it's not. And we know where someone's baseline is, and we continue to help them live despite that. And so what I'm sharing with you is kind of a modified version of ACT, which is focused acceptance commitment therapy. And so it's designed for brief interventions, because it's evidence-based for sort of shorter sessions. And it's a focus on unworkable results of avoidance. So what that means is, if I'm in chronic pain, or if I have anxiety, which there's a lot of correlation between the two, it means I'm spending a lot of energy trying to avoid my pain or avoid my anxiety. In fact, it's creating more anxiety and more anger and more frustration because of everything I'm doing to avoid it. So it creates actually behavioral health symptoms, because I'm just by sheer frustration of my constant avoidance of the symptom. And the next part is the acceptance of the presence of distressing, unwanted, and private experiences. So how do we help patients to accept where they're at? And then choose a life path based on values. So looking at what they actually care about, and then working on aligning that behavior, and then taking actions which propel them down that path. I'm going to show you a quick video, and I sure hope it works. And you guys will have to tell me if it doesn't, but this one is, hope it works. On really looking at the difference between goals and values.
Wendy, we don't have any volume on that. Is that correct?
So no volume, darn it.
I think when you may have to unshare and share again, and when you share your screen, make sure you say share your volume also.
Okay.
Or share your sound or something like that.
Okay. Okay, oh, I see it. Thank you for, all right. All right. Try this again, thank you. Okay.
To be happy is to achieve our goals, get that great job, earn that money, get a good body, find a partner, have happy, healthy kids, have a big house, have a nice car, have holidays. Goal, 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 goal. And it's true that if you do actually manage to achieve these goals, then there is a little moment of joy and happiness. But how long does it last? How long before you're looking at the next goal, and then the next goal, and then the next goal? And as we live our life trying to constantly strive to achieve these goals, one after the other, how tiring and exhausting does it get? Is this you? There is a radically different way to live your life, which is a life based on values, a values-focused life. It's like two kids in the back of a car, and it's a 3-hour car journey to Disneyland. And the first kid is totally goal-focused. Are we there yet? Are we there yet? How much longer? Are we there yet? This journey of frustration, it's all about the goal. The second kid is values-focused. He's got the same goal. He wants to get to Disneyland, but he's also in touch with his values around curiosity, adventure, having fun. So he's looking out of the window, playing I Spy with My Little Eye. He's counting all the, the interesting farmhouses that he sees on the way. He's spotting interesting farm animals, cows and sheep. He's noticing different types of trucks and cars on the freeway. So he's actually appreciating the journey as he heads towards his goal. Now, they both reach Disneyland at the same time. They both have a fantastic time at Disneyland because they both got to achieve the goal. But the first kid had a journey of frustration. The second kid had a fulfilling, rewarding journey. Then on the way home, the first kid, are we home yet? Are we home yet? Are we home yet? All about the goal, all that frustration. Second kid's looking out of the window, noticing how the world looks different at night, spotting the lights in the farmhouses and the cat's eyes on the freeway. The car breaks down on the way to Disneyland. Now, both kids are really disappointed because neither of them achieved their goal. But the second kid at least had a fulfilling journey up until that point. Now, when the pickup truck arrives to tow them home, the first kid, oh, it's not fair. I want to go to Disneyland. How long before the car gets repaired? It's not fair. It's not fair. The second kid starts to notice how the world looks different when you're sitting in the front of a pickup truck high above the level of the rest of the traffic. So this is the very important distinction between the values-focused life and the goal-focused life. In the values-focused life, we have the fulfillment and satisfaction of living our values every step of the way towards our goals, the satisfaction of achieving our goals, and the fulfillment that comes of living our values even when we don't achieve our goals.
All right. So it looks like that came through. All right, so any thoughts on that video? I know it's probably pretty simplistic, but kind of seeing the difference between values and goals there. Anything that stood out to you? You can chat in or speak up.
I think it's very, all of us can benefit from this likely. And looking at the idea of like that curiosity about the surroundings, like even as you're about the journey, that's something that I think is an easier win for people to like, oh, let's just be curious about what's around you right now.
Yeah. Yeah, just even like what's slowing down for the moment and paying attention. That's such a good point. Anybody else? I think we see this often with our patients, right? The goal focused, where the goal is to get rid of the pain or get rid of the symptom, or that my life won't get better until I lose weight, or I have my relationship's perfect. And they're this constant striving. All right. Okay. A couple other assumptions that I feel like in a lot of these, they're things that in and of themselves are brief funk or Chris says we see that in medications as well. Absolutely, they're looking for a quick fix. And some of these assumptions I feel like I've used as brief interventions, just teaching some of these principles in some ways, or breaking some of those in cognitive behavioral interventions, we call them ants. So, you know, sort of those thought patterns that don't help us really get where we want to be. And so one of the things that I like about this too is when symptoms are present, there's a loss of equilibrium. So it's getting rid of sort of the diagnosis. And basically what happens with people, it's when our stress someone's under is bigger than their coping strategies. So there's just a loss of equilibrium between their coping and the stress. So in a brief intervention, we're able to increase their coping to meet the stress. Stress, as we know, is not really good or bad. It's how our body responds. And so if we rise to the challenge, see our body is rising to the challenge versus seeing it as a threat, we're able to help them build some coping around that and see it as a challenge to meet versus avoid. And pleasant emotions are signs that a life's out of balance and they aren't problems to be solved. So we're not trying to get rid of unpleasant emotions. It's just accepting them and being curious about why they're there. I think a lot of times anxiety exists because we're saying yes when we need to say no to something, or we're not living in balance with our own values. And our body is kind of signaling to us through anxiety that something's out of balance. Living vitally is the goal, not living symptom free. That is a great conversation to have with patients and setting that expectation. And that people are not broken, only trapped. I think I see so many patients, they just want to know, am I normal? Yes, they're normal. We're all going through difficult things right now. They're not broken. They're just kind of trapped in their own thinking in a lot of ways. And the goal again is to build confidence so that they have improved coping. There's not a lot of history on focus on history, so I'm not going all the way back into their childhood or anything like that. I want to know how things are showing up today and what are barriers to helping them live. And life is what matters in the long run, how they're functioning. So our goal, even if there is a medication, is to improve functioning. And I can use SMART goals around that, right? So how do I know if functioning's improved? What's going to be different if the pain's gone? What's going to be different if they're not experiencing depression or anxiety? We want to improve functionality. That's the goal. Every intervention's an experiment. Which I really like about that is it's just like a PDSA, what you guys have been learning about. And so when patients have that ambivalence, we can just say, let's test this. Let's do a small test of change and just see what happens. So it's something they can toy around with instead of having a full commitment to. And small behavior change is just as powerful as big change. If someone, starts walking to the mailbox, or they call their daughter once a week, or they, lower 5 Cokes to 4, small things matter because the goal is to build confidence. And so it may just take some time to get there. And I see somebody just chatted in, it's hard to see improvement or positives if they're only focused on the end goal. Baby steps get you to the goal. Absolutely. Yeah, we've got to celebrate the small things, and we have to think about in our own lives too. Change doesn't just happen overnight. It's slow and it's hard, and we have to tie it to something that matters to us so that we can keep going even in the hard times. So that's a great point. And a couple of things, when I'm doing a brief intervention using acceptance commitment therapy, really looking at a couple of things. And this is a 5-10 minute assessment at most. It's quick. It is brief, it's fast paced, but I really want to know who they love, who they live with, what their support looks like, what their quality of their relationships look like. What their work looks like. Do they do volunteer work? What gives them meaning in their life? How do they play? What do they do? And what does their health look like? So quick. And this is a conversation. It's not a screener. And then when we identify the issue they want to discuss, we're looking at time. How long has it occurred? When did it start? How long does it last? What triggers it? What happened before that? When has it happened before? Is it the same trigger, a new trigger? And then trajectory. How does it increase or decrease over time? What makes it worse? What makes it better? So quick, focused assessment. And identify strength and skill deficit. So I'm looking at that level of coping, and then what do we want to add? And then we're just trying to understand what's a story about their pain, what's the context that pain lives in. I see Chris said over half of the patients in a treatment group yesterday remarked that they are broken. Interesting. They brought that belief with them. And so reframing that belief about being broken is an intervention. That's where they're trapped in that belief. And just that alone, that small reframe makes a huge difference. From assessment to problem summary and redefinition of the story, big or small, leading to a behavioral experiment. So that's kind of what we're doing, is a basic behavioral assessment. And this is a quote. I think that it helps us kind of remember a little bit about this too. And this is a great teaching point, that most people find the meaning that sustains them through hard times, not in happiness, but in responsibility. And what that means is, it could be responsibility to your kids, to a cause, could be to taking care of an animal or a relationship. But that's what gets us through hard times, our patience. So it's not happiness that gets us through. It's really responsibility at the core of meaning. And then chasing meaning is better than avoiding discomfort. So our goal in primary care, in behavioral health, when we're working with people, is helping them chase meaning, because if they're spending all of their energy avoiding discomfort, it moves them in a wrong direction and away from what they care about. So valued living domain. So this is a quick intervention that you can have on a whiteboard, you can have on a handout, but it helps a patient really assess how close they're living to their own values. And a big part of acceptance commitment therapy is that the two of you are really looking at the behavior sort of outside of the patient. So it's not you're bad, you're wrong, but let's take a look at this behavior and see if it's working or not. Let's both take a step back and take a look at this. And this bullseye kind of helps them sort of look at and assess where they're at. So having them kind of identify what their values are, what they care about, what matters to them, and then looking at these different domains in their life: leisure, relationships, personal health. Oh, is there supposed to be a black square covering a fourth of your slide? That could be the chat box. So I'll move that.
Thank you.
Yeah, sorry, I'm trying to do both at the same time. And given the time, you guys will have access, but this is another great video on the anxiety switch. And it's a 3-minute video. You can show it to a patient. This author actually has a number of really short videos, and I like to show them to a patient. And again, quick, brief intervention that helps us kind of have a conversation. This is a great grid. Again, this is pretty quick that you can use with a patient. And so the first question is like, what do you do to avoid the experience? So when, let's say it's pain, what do you do to avoid pain? And they might say, well, I sit on my couch all day, or, I don't move around at all. And then what do you experience when you're on the couch all day, not doing anything that you care about? What happens then? And writing that down. And then asking them what they want and what they care about. Having them mark that down. And then what can they do to move toward what they want? What does that look like? And I've actually taken a piece of paper from the exam table, wrote a long line on it, and had the patient put what they didn't want on one side, their avoidance, and what they did on the other side, and then actually have them walk on the line and say, what's it like to move away from what you care about? I mean, when you can have somebody be involved kinesthetically or physically, sometimes in an intervention, they can really identify what that feels like, and then what does it feel like to move towards what they care about? What's that experience like? And these are quick things I've done in exam rooms with patients, and just had the conversation, and it's balls start to drop, and then it's them driving the conversation versus me coming up with ideas. Wendy, if anyone's got a question or comment, I can't see it, so just let me know if anything comes in. Okay, and I've given you just a quick, we could probably spend, some of these trainings could be a couple of days, but a quick primer on some simple things to talk with patients about, to frame the conversations that could be used with anxiety, depression, a multitude of things. I was going to shift in the last couple of minutes, just because immunization seemed to be a big issue, vaccine hesitancy. And you can use ACT or motivational interviewing with conversations with patients too. Because education alone is not effective, especially if it is contrary to their values and beliefs. So we always have to start there. And so this just gives you a couple of ideas about the traditional approach we take when we're trying to talk to someone about a vaccine, any vaccine or any change really. We give the facts, we educate, We use prescriptive language or fear-based tactics. If you don't blank, then this will happen, or it's a talking to. MI approach asks permission to give facts, elicit what the patient already knows, if you want to know what's their understanding so far. Use collaborative, empathetic language, focus on developing discrepancy, and you're working with them to figure out what's best for them. This is informed decision making. Really walking through, what do they know? What do they care about? What are they worried about? Really understanding that allows you to get to something deeper. So in this, you can kind of see an example here. A patient expresses hesitancy about a vaccine, and the MI approach is, you're due for the following immunizations today, but I heard you decline from the nurse. Do you mind if we talk about it more today? So they're asking permission. And then the patient says, okay. And then their provider's eliciting what the patient already knows. And then the patient says, I heard you can get sick from the flu, or it could be anything. Or I might feel sore, my arm's gonna hurt, or someone died. And then the provider says, you're worried the vaccine will make your arm sore and you might feel sick. Yes, I can't take off from work to deal with it, so that's why I can't do it. And then the provider says, maybe many of my patients are concerned about safety of the vaccines and whether they're more likely to get sick from the shot than from the actual disease. So again, the provider's still asking questions, reframing. You can see a really good example of a reframe there, or I'm sorry, reflective listening. And then the patient, there's that exactly, that's your, that's right, versus you're right. The patient's like, yeah, the provider gets it. Ask to provide information. Would you mind if I provided you more information about X disease? You have all the facts before you decide. So again, asking permission, and then the patient says, sure. And so then they're able to provide the information and go from there. And then ideally the provider would say, so what do you think about that? But you can kind of see that's a different conversation. And Connie passed this on to me as well. It's called BRAIN. It helps patients make a decision. This is another brief intervention, very simple, looking at benefits, risks, alternatives, intuition, and next steps. So kind of walking through a decision tree with the patient to kind of help them make that decision. And there's an app for that. And so you can search for it, and patients could use this to help them make other decisions as well. And actually, I'm gonna pull this forward. This middle book here, Brief Interventions for Radical Behavior Change, highly recommend. Anyone can use these brief interventions in primary care or behavioral health. That one I'd recommend. Again, most of these can be done in 10 to 15 minutes with a patient, great for a variety of chronic health conditions, mental and physical. And then these are some apps. And you guys might have some of these, but these are a number of apps that a patient could also use to help reinforce some of these things that are built off of motivational interviewing, a lot of them, and ACT. So it kind of reinforces maybe some of the things that you've done. So with that, 1 minute, and being a good behaviorist, I should ask, what is one thing that you can try out in your next patient visit or client visit? What's one thing maybe that you learned you could try out yourself? So anyway, I realize that we are right at time, or maybe about 1 minute left. Any last comments, thoughts, anything anyone wants to share? There was a couple of things. They want the slides, yep. And a couple of things. Thank you guys. I always enjoy being with y'all. And if there are any other questions, feel free to reach out or send them to Wendy and she can get them to me. But more than happy to send additional information if anyone's interested. All right. And
Thank you, Wendy. This is great information shared. For those on the phone, if you guys are not received the large WPCC distribution email, feel free to drop your email in the chat and I'll make sure that you get it. I've written down a few resources that I will make sure that I send out, and I will make sure this recording gets sent out as well. And with that, many thoughts of appreciation in the chat box to you, Wendy. Thanks for joining us. And thanks everyone for participating. Have a great day.
All right. Thank you.